but I can tell you that in Australia, 50% of physios leave their profession
Yeah.
before 10 years after finishing the
Yeah,
degree.
yeah, for sure. But the problem here, I think that those people leave their profession because they leave their profession like I'm the solver of the pain of the patient. Altra chiacchierata, altro video, altro dialogo molto interessante con una persona interessante di cui sto parlando, di Diego Hidalgo, che molti di voi conoscerete come The Skeptical Physio. Quindi guardate anche nel link in descrizione, ci sarà il nome del suo account Instagram dove diffonde tanta conoscenza e dove porta molti terapisti a mettere in discussione se stessi e la propria pratica. E questo che penso che sia un tema molto importante da tenere in considerazione. Ne abbiamo già parlato con Thompson, di fatto un elemento che può permetterci di evolvere davvero tanto come persone e come professionisti è adottare sempre una mente curiosa, una mente da scienziato che possa mettere appunto in discussione quello che facciamo. Sono usciti dei temi a cui non avevo pensato, sono rimasto molto sorpreso ed è bello sempre poter riflettere in questi termini e porre il focus su come facciamo le cose, sul perché le facciamo e cercare sempre di migliorarsi. Quindi proprio per questo motivo attento o attenta a quello che verrà detto, goditela perché ci sono cose davvero interessanti e soprattutto poni il focus su il mio inglese. Quindi per la seconda volta avrai modo di gustarti il mio inglese e vedere se c'è stato qualche improvement. L'obiettivo a fine dell'anno con tutti questi video è di arrivare con un inglese super fluente. Chi lo sa, vediamo. Intanto usciamo sempre dalla zona di comfort per migliorarci. Okay, here we are. Diego, thank you so much
Thank
for
you
your
so much, Matteo.
and it's a pleasure to chat with you. And it would be great if you want to talk a little bit about you.
Of course. So I'm Diego Hidalgo, and you may know me by the name of Aesthetical Physio because that's my my social media account. I studied journalism and worked in a newspaper for 1 year, especially specifically in the economic department. After that, I realized that though that kind of work wasn't for me, so I shifted my career towards studying physical therapy. I finished my degree like 2 years ago, and since that time, I've been working in a hospital in Madrid, especially or usually dealing with patients with musculoskeletal issues and also sometimes sport patients like ACL reconstructions or Achilles reconstructions.
Well, you do a lot of stuff.
I do a lot of tasks. Yeah.
Yeah, yeah, and I appreciate a lot your work on social media because I like people like you that try to talk about the importance of spreading knowledge at ABP practice.
Of course. I think that sharing information, especially is, if it's well intended, and I'm trying to make it like the closer thing to truth.
Yeah.
I think that it's always important to share that reality because, in my opinion, many degrees are choosing to keep up with the old ways instead of like saying, okay, let's take a step back and see things with perspective and decide what things we should get rid of and what new things we should include in our educational programs.
Yeah, yeah, great. And it seems that you like to think and to go on the future, no? To leave the past and go on the future.
Yeah, I think that I don't know which philosopher said this, but we are always living in the present. The past is like something that will always exist, and the future is something that haven't existed yet.
Yeah.
So I think it's more useful to use what we know from the past to construct a new future to some
Yeah.
extent, if it
Living
makes
the
sense.
present, living the present.
Yeah.
Create
Uh,
the future, but living the present. I think that a book that talk about that is, oh, you go away.
no, but I'm here.
Yeah, yeah. The book, I don't know if you know it, is by Edward Toll. He
Mhm.
talked about mindfulness
Mhm.
and said that the only moment in the life is the present. The past
Yeah, yeah, of course.
predicts the future also.
Yeah, yeah. It's like, do you know the Tomorrowland festival? You know
Yeah, I
what's
love.
their slogan? It seems something like, tomorrow is a gift, today
Yeah.
is a present, and yesterday was a, I don't know, something like that. Yeah.
Yeah, something like that. But yeah, I know. You don't remember because that tomorrow you can't remember about what past.
Exactly. The future is blurry.
Yeah. And talking about that, I would like
Uh-huh.
to chat a little bit about this topic that
Yeah.
for me is very interesting, and
Mm-hmm.
it's this one that now a lot of people focus on scientific evidence. What
Mm-hmm.
tell us what to do, what to avoid, in short, the purely technical aspect of clinical practice.
Mm-hmm.
The idea that if I increase my knowledge, if I know everything about pain, if I know every paper on the earth, I am a
Mm-hmm.
better clinician. What do you think about that?
Well, I think that the evidence-based movement is kind of a response against the tradition of our field, because our field is quite uh, experience-based, if you want to say it.
Yeah,
And I think that many clinicians have grown dissatisfied with the current environment of our field, in the sense of, do what I do because that's what we have always done. And because we have always done things this way, it must be the good way. And to some extent, because the evidence-based movement started in 1996 or something with David Sackett and Archie Cochrane. If you know about the Cochrane organization, he's the guy. They did that for medicine. It wasn't never intended to be applied to physical therapy, but some people within the field, I think that decided that this was worth to give it that a shot,
yeah,
and try to replicate the things that medicine was trying to achieve in physical therapy. I think that we don't have still like an evidence that has the quality that many medicine fields have, unfortunately, because that creates a let's say many uncomfortable situations, because you don't really know how to proceed many times, because your
yeah,
patients may not align with the evidence that you are reading. Also, to some extent, I think that is an illusion, in the sense that the people that is creating content, the people that are creating content on social media with scientific purposes in the field of physical therapy, really don't think or don't believe in what they are saying, to some extent, in the sense that they of course agree that they know these shortcomings, and
yeah,
they are doing a lot of things just by going guided only by experience, because we don't have an evidence that we can use to replace that experience. But it's true that to show the, let's say, our face or the scientific evidence in the best light possible, we sometimes, I think, sing to um, make things, or make it look like we are constantly like doing everything guided by evidence. But that's not the case. I do many things guided by experience, because I don't have any evidence to suggest I should do things in a different way. And I can assure you that everyone, like the Adam Meekins, Ben Cormacks of the world, are doing many things guided by experience, because unfortunately we don't have any evidence to say things in a different way, or to guide some of our actions. But at the same time, I would say that it's always important to never lose track of our aim, or because at the end, I think this is kind of a mission of trying to spread what we believe that is appropriate knowledge, and we should keep going, let's say, blazing that trail.
yeah, yeah.
So yeah, I think that we need to keep in that way. But for the listeners, don't worry, because we do many things guided by our experience and not by scientific evidence at all.
Yeah, you have. I like a lot what you are saying, and you have to keep going on
Mm-hmm.
a track of scientific evidence. But
Uh-huh.
remembering that the clinical encounter is more more different because people are people and you have to improve and to make improvisation in every contest, in every day, and in every people because the person that came in your studio today is different in another day. So
Of
you
course.
have to adapt yourself. You have to be capeless.
And there's a pieces by a paper by, I think that it's Seth Peterson, and the paper is called like becoming a clinical chameleon.
Mhm.
And the concept of the clinical chameleon is really cool in the sense that you need to change according to the patient that you have in front of you. You will know that like the personality A, B, C, and D, depending on the patient. For some patients, you will be like really like polite, and you will be like always there, really present. And for some patients or for some friends, because this extends also to that field, you will be like always making jokes and always like trying to find, let's say, something to criticize or something like that. So the clinical chameleon concept is in that sense applicable to many of these instances of, hey, the patient that you have in front of you may require you to be a different person or change, modify to some extent certain pieces of your certain pieces of knowledge to apply to them. And then let's say if you read a paper on spontaneous reabsorption of these sequestrations, and you have three patients that have this sequestration, you may need to reframe that message in different ways for
Yeah,
the three of them to reach the same conclusion. So
yeah.
there's nothing wrong with being adaptable, and it's literally the opposite. The more adaptable you are, the fittest you will be to survive,
Yeah,
like
yeah,
Darwin
yeah,
would
yeah.
say.
Beautiful. It's a great point, this one, because if you are too much attached to evidence, you can't feel the person in front of you. So you can't adapt and you can't go inside the world of the person in front of you because I just want to share with you an experience with a patient yesterday. Uh,
Mm-hmm.
she is a teacher of musicians.
Uh-huh.
To go in her world to make her safe, I started to talk like melody. You have to move your body with melody. You have to feel
Mm-hmm.
the sound of your body. So I started to use words and ideas, image of her world, not my world. And
Yeah.
so this is very useful, I think, also in some moment like when you have to do a little of pain education, maybe,
Mm-hmm.
no? Or when you make pain education with the use of the body, because this is
Yeah.
another part.
Of course, of course. I think that it's really important to always, yeah, adapt to the patient that we have in front of us.
Yeah, the problem I think, and the problem that I said very times, a lot of times, sorry,
Mm-hmm.
is that the therapist continuing to follow evidence based because it's an idea of an increase of certainty, but
Mm-hmm.
and I think that you have to know that you have to stay in uncertainty and you have to be safe in this case.
Yeah, I think that what we are trying to do is kind of build small islands of certainty. We want to delimit the things that we don't know to create let's say, the small pieces that we know are probably true. And from those islands, we are trying to, let's say, uh, and become creating like an archipelago, like a group of islands, with the hope of someday be able to finish those or to mixing those islands, so we create a continent of certainty. And I think that during those struggles we may commit some mistakes in the sense of being to adhere to the evidence.
Yeah, yeah, because at the end is the same similar process of the patient.
Mhm.
The idea that I have to follow a specific solution.
Yeah, that's like clinical guidelines.
Yeah.
We are always kind of yapping about clinical guidelines, always like saying that physical therapists don't follow clinical guidelines, and that's a bad idea. And I agree to some extent that we may be doing or say, especially saying things that do not align with those clinical guidelines and do not align with like the appropriate care. But I would like to say that sometimes clinical guidelines are created by experts that may not have like, even if it sounds obscure, they don't have the clinical evidence to the same, let's say, extent that we have. So sometimes those clinical guidelines are usually not well written in the sense that they may misguide us.
Yeah, yeah, for sure. Yeah, you have to be open to criticize the guideline also and your work.
Of
Over
course, of
here.
course.
Yeah, yeah. And I think that in this case it will be interesting to talk about the
No,
fact that
no entres, por favor.
Oh, okay. No problem. The thing that the therapist at the end have to work on himself, both physically and psychologically, to embody a part of evidence, a
Mhm.
part of clinical guidelines or strategies.
Yeah, of course, of course.
And what do you think that is the limit for this improvement?
Uh, well, I think that to some extent, many, I think that this may sound like controversial or that I may look as a hater, but I think that a lot of the studies that are currently being produced in academia, especially within universities, lack a lot of value if this in the sense that they are created only to fulfill the requirements to keep teaching.
Yeah,
So if I told you that you need to produce 30 papers in let's say 1 year, you're going to produce 30 papers that lack a lot of quality and they may not help us at all as a
hmm,
profession. So to some extent we should reduce in my opinion the requirements or the impositions, because sometimes it feels like you have like two paths to create science: the one that is official and lacks quality, and the unofficial that is harder to produce and should have more quality, but because you don't have any funding,
yeah,
it's going to end up like in a halfway, like halfway done. So the things that I think that should happen in that sense are, we should spend let's say create much less evidence. We should write many less papers, um, and focus all our funding in like a few papers that aim to answer the question in the best way possible.
yeah,
And that should always or should also be guided by our aims to, let's say, destroy certain papers, in the sense of there are some papers that should have never been written down,
yeah,
and they should never exist because they are kind of confusing us due to the lack of quality. And we see that a lot of time, because you may write a letter to the editor saying, hey, this paper is not trustworthy because A, B, C, D, and E, and I think that it should be retracted. And they will say, look, they always respond like, we are happy you think that our paper lacks quality due to these reasons because A, Y, and Z. But things never change, and you may have a lot of papers that, because the author paid for it, will always be stored in the internet and confuse our field. So in
yeah,
that sense, we should get rid of like, I don't know, 80% of all the papers that exist in physical therapy and rewrite many of those questions again, because you may have tried to answer that question, but in a way that doesn't add anything valuable to us. So yeah, I think that we should write less papers, but with better asked questions and with more funding. And we should also retract many papers from our
At the
field.
end, less is more.
Yeah, addition by subtraction. Like there are, I don't know, I am saying 80%. I remember there's a piece by Iwanides that is called Why Most Published Findings are False. And he says something like, I don't know if the 95% of papers had some issues that make it harder to be like trusted, to
Yeah,
trust the findings completely. And I agree to some extent, especially in our field, because our field is famous for lacking a lot of, like, say, let's say, methodological and statistical components. We don't hire a statistician to create our papers. We just go with the flow and say, hey, I'm a one-man army and I can do statistics, methodology, recruitment, teach,
Everything.
uh, work at the clinic, write a PhD, guide people writing their PhDs and all that stuff. And at the end, you're a jack of all trades, but a master of none. And especially, you're not a master of research in that sense.
Yeah, yeah, and this is a problem because create in some time a lot of confusion for people, for students, also therapists that they want to know more about pain or other stuff, and it's a limit about the research. And what do you think about the limit of teaching?
Well,
Teaching,
ideally,
sorry,
teach.
teaching, I try to make
Mhm.
another question. Teaching about what is important to
Oh,
develop
okay.
like clinician.
Mhm. Well, I think that clinicians that have been working for a while probably know what's important to some extent, but I think that those things may get lost when you try to teach them, because if you spend a lot of time in the clinic, you may be corrupted by the experience to some extent and forget about the evidence.
Yeah,
um, Also, we have like different ways to interpret our experiences. So you may have, like, let's say, a department teaching certain subject, and you need to reach a consensus with the other lecturers because the exam is going to be the same for all the groups, and that creates, let's say, bad incentives, in the sense that consensus usually leads to probably the, let's say, the survival of the strongest, because
yeah,
there will be people within the department that will have either more power or more people that think like them within the department, and that may leave you to sacrifice what's really, let's say, important, or especially ways to reconceptualize the way in which we are treating in the clinic, to impose
mm,
the same traditions and,
yeah,
let's say, misconceptions and shortcomings that may emerge from being led by a lot by your experience. And that's, I think, really common, that you are being taught things that go against both, let's say, the evidence, but also, let's say, the middle ground that we are trying to find. Especially Greg Lehman does this a lot, if you know Greg Lehman, that he say, look, I know that the experience says this and the evidence says this, but I believe that there's a middle ground where we can just, like, reframe the narrative and still keep doing that treatment, but in a different light. And I think that usually what I'm seeing in academia, not in academia, but in universities, is that people go with the left instead of going, like, I haven't had a teacher that was like too much into scientific evidence, that I thought, look, this guy is too involved with science. He's too obsessed with that. I usually see the totally opposite. Like, no, this guy is totally obsessed with tradition, with experience, with the things that have worked for him, and the explanations that he has given are the explanations that he's teaching us. So yeah, I think that's the answer.
yeah, yeah. A lot of things.
Yeah, a lot of things. Yeah, sorry.
No, 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 no problem. I appreciate a lot because at the end, this is the situation, and we have to talk
Yeah,
about this situation and the contextual factors also are on the academy and other part.
yeah, like, let's say, the mess that we have in the clinical world also exists in academia,
Yeah,
for both giving classes, teaching classes, and doing like research.
yeah, because at the end we are person with person, so there's no.
Yeah, and usually in, I don't know, because again, this may sound a bit controversial, but the people that are creating research are the same people that are like treating patients outside usually.
Yeah,
So sometimes I wonder to what extent we are like trying to do everything, but we are becoming, as I said previously, mediocre at everything, because I think that it's frowned upon when you have a clinician that has left, let's say, the clinical world to focus completely on research.
yeah,
And we are usually pushed towards, no, you need to, let's say, work 30 hours teaching and researching, and you need to spend 20 hours in the clinic, and you think, well, that person needs to live.
Yeah, yeah,
He or she probably has family, kids, hobbies outside, physical therapy, and all that stuff. And something, you need to sacrifice something. And I think that sometimes what you're doing is sacrificing a bit of everything. And you may not read, for example, the new papers that are coming, or the you're not listening to podcasts for people from people like, for example, Greg Lemon, making sense of those things. So I think that I could be totally fine if I had lecturers that only devoted their time to lecture and research,
yeah,
and were not clinicians at the current time. Like I agree that you need to practice for some years probably, but after some years, you probably have uh, you probably have a lot of questions that haven't been answered, and you say, okay, I'm trying to devote all my time to answer them. I don't need to keep going, or hitting my head against the wall with the same problems again and again. I prefer to devote that time to answer the question in a scientific way, in the best way possible.
yeah. You have to follow your values at the end.
Yeah, yeah,
What
of
you
course, of
feel,
course,
and this is important because you can do everything at the end fine in a good way,
of
no?
course.
You
Yeah, it's
can
impossible.
be,
It's
you can
impossible.
be a researcher, better clinician, entrepreneur, friends.
Yeah, like you are constantly changing your hat, and now you're a researcher, and you take the hat off, and now you are a clinician, and so on. And at the end of the, and I think that that leads to burnout a lot, because again, and I'm changing my thoughts about this in general, but I think that we should try to diminish how much physical therapy or our job means for our identity, and we need to shift towards other hobbies that have nothing to do with physical therapy. Because if your life, let's say, goes around or circles around one thing, if that thing goes wrong or doesn't give you the satisfaction that it used to, you are going to have a really miserable time trying to get out of that hole. And I don't know. I'm trying to let's say combine both worlds,
Yeah,
but I do agree that it's really important to reduce your identity as a physical therapist as much as possible, even if it sounds bad, because of course you can devote all your time like reading research and all that stuff. That's totally fine, but I think that it's the way in which our field is configured at the moment makes it really easy for us as physical therapists to get burnt out.
yeah, yeah, yeah. Yeah, it's difficult from one side because you are very passionate to this world, to help people, and so you feel energy to do that. But
Mhm.
to the other side, you have to think about what you said before, because you are a person that live in a context with the family, with people. So if you start to take away your hobby, your values about of people, not clinician. Also
Mhm.
the clinician maybe start to get worst because
Yeah,
and if you are not okay like people in the world, you can be a good clinician.
of course.
No? If you work in a person-centered care also. If you make only manipulation, maybe it's easier to do one side because you don't have to deal with people to talk, to feel emotion, to be present. No, you can do like a mechanical pathway.
Yeah, and that's something that I was very adamant as a student, because as I told you before, I created the skeptical vision during my second year of my bachelor, and I will talk with my friends like, look, let's read papers now and discuss them, because I believe that once we are working, we won't have the time or the aims to keep reading them. And they say, no, 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 we will read it once we finish, because we don't know, we right now we don't know enough to, let's say, uh, ascertain what is true from what is wrong. And here we are, like 5 years later, and my colleagues still don't read papers. They never started, and
Uh-huh.
now they are busy. Like some of them are busy, like performing manipulations or doing like the passive therapy that we may criticize in that sense.
Yeah, yeah, yeah. Yeah, it's an interesting part, because at the end also there are some people that make work like a machine, no? Okay, like the colleague that you say that are busy, but they make manipulation and go in this way. Uh,
Mm.
um, there are a lot of people that are not satisfied by their work because they feel a gap from the the scientific evidence, the clinic, and then I think that a big problem is related to your feelings. So, cioè,
Mm-hmm.
you you start to lose the connected with yourself, your identity, and
Mm-hmm.
it's important for you, and what are your values, and so you are too focused on clinic, and you have maybe to be more focused on what you like, what are your worries, what are your goals, what are of person. Because if you don't work in this way, you take those problems you put in the clinic.
Yeah.
Uh,
Yeah, or the opposite, the problems from the clinic, arrive at home and you start thinking or keep thinking about those same problems. And I think that it's really hard to, let's say, separate both worlds, in the sense they always will tell you, no, 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 you just need to leave the problems of the clinic at the door of the clinic. But that's really hard, especially if you care about the patients. Not always, but many times you're going to say, look, I'm going to read some papers about these conditions in the aims, in the hope of be able to improve the condition of this patient. But at the same time, as you said, you arrive at home and you are like a bit angry or maybe exhausted. You have some anxiety because those patients are not working out,
yeah,
and you are going to pay that to some extent with your family, and you are going to diminish the time that you are spending doing your hobbies.
yeah,
And I would like to remind the listeners that we are persons beyond or before being physical therapists. So as I said before, if our whole identity circles around being physical therapists, and physical therapy doesn't go as we intended when we started our career, we are going to have a very miserable time, and we are seeing high rates of people leaving the profession. I think that I don't have the, let's say, the data for Spain or Italy, but I can tell you that in Australia, 50% of physios leave the profession
yeah.
before 10 years after finishing the
Yeah,
degree.
yeah, for sure. But the problem here, I think that those people leave their profession because they leave their profession like I'm the solver of the pain of the patient. So
Mhm.
I'm it's all about my own. I have the responsibility to take the pain away from the patient, but it's not possible. So you have to take the responsibility of the relationship, maybe, or to make a good work at the end,
Yeah.
and to be open, to show trustship and kindness and
Hmm. Yeah. I think that we need to reframe how we conceive physical therapy and our role
yeah,
within the field. But I also think that there are many physical therapists that are well intended and maybe or probably are reading scientific evidence. They are spending a lot of money in courses and listening to podcasts and all the stuff that we encourage to do. But the job conditions usually make it really hard to, let's say, enjoy the path. If you feel me, because you can work at a private clinic, for example, seeing, let's say, one patient per hour, but you can also work at insurance-based settings where you are going to see many patients. For example, right now I'm working in an insurance-based center, and I don't know, I'm dealing with 50 patients per day, and
okay.
that makes it like really hard
Oh,
to
yeah,
work in the way that I envision. And if you also mix the wage and all that stuff, that it's really important because at the end we have jobs because we want to we may enjoy our jobs, but we also need to make a living to keep existing. And
Okay.
if those job conditions are not worth it, you're going to rethink your career and think maybe I should go to a different field. And that things, I believe that that's one of the main reasons why physical therapists are leaving the field, because there are some surveys out there that are suggesting that the lack of progression,
Yeah.
because you are born a physical therapist and you die as a physical therapist usually, that lack of progression and also the job conditions make it like really hard for many physical therapists to to remain in the field for, I don't know, 20 years from now on.
20 years to make 20 patients per day to make the same stuff. It's crazy. And
It's exhausting, yeah.
exhausting, and the problem maybe is the society that no, create this kind of vicious cycle that no, also the people think that the therapists have to take off the pain, the clinic is creating that way, the therapists think in that way, and so the therapist starts to think about, oh wow, I have to do 30 years in that pathway, and
Yeah,
it's
no,
crazy to think about that. And
it's a road towards burning out. And in that sense, I think that um, our expectations are created by our environment. And if our friends tell us, no, no, go to that physio because he's going to solve your problem in one session, or the media says, I don't know, the physical therapists are famous for dealing with, because I think that's the impression that we give to the outside, like we can fix problems, usually pain, in one session or two, like doing manual therapy. That's, I believe, what most people think physical therapists do. And when you propose a different alternative, like, no, 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 we're going to do these exercises, or even if we try to reframe narratives, I have a lot of issues usually reframing narratives, because that people is comes from, let's say, an orthopedic surgeon that told them that, from the radiologist, their family told them also, oh no, no, I had that problem and I went to surgery, and they arrive at your door with a lot of preconceptions, usually misconceptions in that sense. And what I'm supposed to do, I'm supposed to be more trustworthy that three physicians, your family, your culture, the media.
yeah.
Sometimes it's about battle uphill, an uphill battle, and you keep trying to fight. But it's true that sometimes it's like, I'm not going to reframe that belief because I'm going to lose the trust from that patient, and
Yeah.
I may need to roll with the punches in that way and try to find a way that I can improve that patient, and at some point maybe try to reframe that message if he or she trusts me.
Yeah, this is a critical point because
Mm-hmm.
times if you go straightforward to change the belief on say that the doctor said bullshit. It's not true that your pain is from your herniated disc and blah 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 blah. You go in front of the doctor. So
Yeah.
the patient trusts the doctor, and so you create a big fire effect also. And
Uh-huh.
this is an interesting point because I read your post maybe some times ago, and
Mm-hmm.
up to you because it's interesting to talk about that.
Mm-hmm.
So talking about that is not important every time change the belief, but
Yeah.
maybe more important to change the behavior, the action of the people, and maybe at the end the belief could change, but
Mm-hmm.
I could have a belief in my head, some in some part of my head that say it's danger to lift weight with the straight with the flex spine, but
Mm-hmm.
I can at the end flex my spine when I grab an heavy bag.
Yeah, and that's the writing reflex that we
Yeah,
call it.
yeah,
And yeah, I think that the writing reflex is probably a way we have unconsciously to show the patient that we know what we're talking about and that we are the experts in that sense. But the writing reflex probably has led to many heartbreaks in the therapeutic relationship, because many patients will I think that happens a lot with, for example, personal trainers. The idea of toning muscles, like, no, no, I want to improve the tone of my muscles. And
Yeah.
the personal trainer will say, oh no, but toning doesn't exist. In reality, what you are doing is reducing your fat body percentage and improving your muscle composition, your fat free mass composition. And the patient, or the well, in that sense, the client will say, this dude is stupid. Like, I'm going to go for a guy that is going to tone me down, and
Yeah.
I don't want to work with this guy. So the same thing happens for us with the writing reflex, and we are always trying to correct all those beliefs when the patient just arrives. There's a place to change some of those beliefs,
Yeah.
but I can say with certainty that most or all patients have a lot of wrong beliefs that we will never be able to reframe, because they are being constantly uh,
Confirm the
bombarded by
confirmation
the
bias from society and
from
from yeah,
exactly.
experience. Yeah, yeah.
I think in that sense, I don't know if you know Derek from Derek Miles from Barber Medicine.
Yep.
He's a really a good physical therapist, and he's very blunt with his takes. He said, um, "I'm going to tell you what you need,"
Yeah.
and that's where I link with Eric Meira. Eric Meira, the science PT. He says, "I'm going to tell you what you need, but if you want to do something that I don't want you to do, for example, you want some kinesiotaping, or you want the fucking lasers and all that fucking
Yeah.
stuff, do it. Like, as long as you do the things that I need you to do, you can do whatever else you want beyond the clinic. Like, if you want to use kinesiotape, I'm going to give you away a free roll, and I'm going to teach you how you can do it. But if you do the things that I want to, you are free to do those other things, because I'm not going to. Or he don't say this last part, but he thinks, I'm not going to fight with every patient that wants to do things that I don't agree with. As long as they do the things that I want them to improve, I'm fine. I don't want to engage in those battles, because it doesn't make sense, and it requires a lot of time that usually we don't have.
Yeah, yeah, yeah. At the end, I think that it's important to show this reflection to patients. So this is the situation. What do you think at the end? We can do this. It's your choice, and this elicitate the autonomy of the patient. And so it's a way to put an element on the table and say, this is
Mhm.
your choice from one side, and from the other side is. I make an experience with your body. Okay,
Mhm.
the experience like expectation violation expectation. I don't know in
Yeah, yeah, yeah.
do you understand?
Yes.
And I make this experience.
Mhm.
The experience is the best part. So I ask to the patient, okay, you have a belief, but what do
Mhm.
you feel with your body? What your body is feeling now? Okay, you can have the belief, but your body says something different. So what do you like? The belief or your body experience?
Yeah, and you remind me of a saying that says, like, we remember like 10% of what we read, 20% of what we
Yeah,
write down,
right. Yeah,
and 70% of what we practice.
yeah,
So expectancy violation also always work in that sense. Like, you have a number of preconceived ideas and experiences about, let's say, a movement, and you say, look, when I bend my back a lot to pick an object from the floor, I have pain. And you, for example, let's say that you grab, let's say, a step, and
yeah,
you put that object above the step, so you reduce the potential range of motion,
yeah,
and you say, try it again.
yeah.
And he say, no, 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 because I'm going to get hurt again. No, no, trust me, please. And they do it, but because you reduce the hardest part of the range of motion, which is let's say, the lowest part of the lift, and this, thinking
Yeah.
about this action
I
as a deadlift.
graded exposure. It's like,
Yeah.
is like,
And if you convince them, like, they do it and they think, oh, that doesn't hurt. Why?
yeah, yeah,
And then you open let's say, a situation or a space where you can engage in that conversation and say, look, I'm going to explain you this in biomechanical terms.
yeah,
Don't worry. about this because we can build your capacity and we can adapt. There's nothing wrong. If there wasn't, I say this a lot with patients that come with an MRI saying, no, 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 because I have this radiological findings.
Yeah.
And that's the reason I have pain. And we do certain movements that they don't have any pain with. And I tell them, do you think that if that structure is really causing you issues, you wouldn't have any pain,
Yeah.
like doing this action, and you are doing it completely pain-free? Or sometimes, let's say a patient comes with a lot of fear induced due to radiological findings, and they say, no, because I have 6 protrusions and I have calcific tendinopathy, and a week passes or so, and the patient has fully recovered,
Yeah.
and you say, do you think that those 6 protrusions just went away because I'm a magician? Or do you think that this protrusion or those findings are there, but were not the cause of your problem?
Not the problem. Yeah. Yeah,
Yeah.
but this is a process that is very useful, I think, to make the experience and later ask. And but if it's their nation disk, what do you why is possible to do this movement without pain? You know,
Of course, of course.
in silence. Not say to the patient what is the answer, because sometimes we see in a lot of our students that they try to calm the gap, the silence, because I'm not able to stay in the silence. I have to say words. I have to say to
Mhm.
you what is happening, the correct reflex, and this is not useful for patients.
Yeah.
Um, and it's beautiful work in this way. And I share with you an experience of yesterday also, a patient that I said lifted this way from
Mhm.
town. He lifted and he left. Well, I don't know okay, do you
Don't
understand?
worry, I understand you.
And I say to him, what is the weight? What do you think that is the weight? And he said 3 kilos, and was 24 kilos. And,
Yeah.
and so this is interesting because the implicit belief, creates
They couldn't lift more
doubt.
than 3 kilos, and
Yeah, wow. What do you think about what is your confidence about your back? 3 kilos? No, you can do more, 24 kilos.
yeah, and I think that you you brought a really interesting point, because we are now at a point in our field where we are saying that strength training, in the sense of heavy loads, don't help for pain. But even if, let's say, changes in improvement in pain, in the trajectory of pain, are not correlated with
Yeah,
changes in strength for many patients, we can use heavy loading to reframe certain narratives, because many humans are told this fragility mindset of, no, 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 you can live more than that, you can. I remember I had like uh, 3 months ago an oncological patient. She came after some breast cancer surgery. She had a lot of lymphatic part of their lymphatic system removed, and she was told by the physician, like, you will never be able to live with your right arm anymore. You can lift things, but not beyond 2 kilos. And I need to admit that she came to the clinic convinced that she could lift more than,
oh, oh,
because she was exposed to a good physical therapist
oh,
during rehab, the prehab, let's say, that convinced her, like, you can do that. But it was really cool that she will say, look, I'm lifting and doing rows with 40 kilos and I'm perfectly fine. There's not any kind of pain. I feel confident again that I can, let's say, for example, pull an object towards me, or push an object, or I can lift a box above my, because she was told that she will never be able to raise her arm again, and she was like doing a bench shoulder presses and bench presses and all that kind of pushing movements
yeah,
with many more kilos than the one she was prescribed or limited to by the physician. So I think that there's still a conflict when it comes to loading between physicians
yeah,
and physical therapists. And what we are seeing time and time again is that loading is, weight training in general as an activity is one of the safest, if not the safest sport that is out there, because everything is static to some extent,
yeah,
everything is controlled, you can choose the load, you can just like get let the floors drop,
Yeah.
and there's nothing wrong with that. And at the same time, many people are afraid of lifting weights because they think they will like destroy their bodies, their muscles will turn, their bones will break, and all that stuff. And I think we have still a lot of job ahead, because if you check the OMS organization for the it's
Yeah.
not the in English is the WHO. Sorry, I
Yes,
said it
yeah,
in
I
Spanish.
understand. Yeah. OMS.
Organizzazione Mondiale della
OMS,
Salute.
Organizzazione Mondiale della Salute. Yeah, yeah.
It's the WHO. It's the WHO. And the WHO recommendations, guidelines for exercise are like not met by almost anyone, like maybe 20% of the population. And I think that's even an exaggeration, because they don't have into account many places, like, for example, I know continents like Africa, for example,
Oh,
we don't have a lot of data of what's happening there. So what we think is from the West, mainly from Western countries, it seems that 20% fulfill this criteria, but those let's say those fulfillments are collected in a survey. And what we know from surveys is that people always exaggerate what they are doing, because they know that they should do exercise, that they shouldn't smoke, then they should read more books. And when I read those
yeah, yeah.
surveys, I'm like, there's no way this data are true, because I live in the world, I live in this reality, and I can tell you that there's no chance 20% of people are meeting the aerobic and
Yeah,
strength
yeah, yeah,
combined
yeah,
guidelines. It's impossible. So
yeah,
we have, in
yeah.
that sense, I think that we have a huge market ahead, market opportunity, in the sense that we can train a lot of people that probably are afraid of aerobic and resistance training. We can be that nexus, that, let's say, the bridge that connects both entities or both worlds. But we still have a lot of changes or reforms that we need to have within our field before we are probably in the appropriate spot to do that.
We have to change the narratives.
We have
Or,
to change the narratives. We have to change the programs, academic programs. We have to change research. We have to change the role we think we have as physical therapists. We need to change the expectations of both patients and clinicians, their family and friends. We have like truly, like that my logo is
yeah,
Sisyphus, like pushing
yeah,
the boulder uphill
yeah,
because he
yeah,
was
yeah.
punished by the gods. I think that's a great reflection of our situation as a profession.
Yes, the analogy for us is that we say a lot of time that we are like salmon. Do you know the fish?
Yeah,
So
going
in
against
not
the
right
mainstream.
direction every day. But
And once we reach the place to reproduce, we die.
yeah, yeah,
Yeah,
but
like
I hope that it's not the end. But
we just finish exhausted, and
yeah,
we just die.
yeah, or
A beer.
from the ball that you are pushing it up.
We have three options.
Yeah,
Either we never reach the destination, a beer eat us alive,
yeah,
or we
yeah.
reach the place that we want to and we just die.
We'll see. We'll see.
We
We'll
will
see.
see,
We
of
will see.
course.
But since this is a good journey, like we choose this kind of journey, so we have to deal with that.
Yeah, and I think at the end, all journeys, no matter what profession you choose, are going to be hard, because I think having a job is the best way to know how reality works.
Yeah,
And reality usually sucks and destroys many of our ideals. When I say ideals, I say idealisms in the philosophical term.
yeah,
And in that sense, that struggle to reconcile reality and our ideals, or to make ourselves compatible with reality, creates a new way to, I think, conceive life. And that may lead to a lot of, let's say, depressive thoughts. But if we can surpass them, that nihilism, we talk about the new grad nihilism, when they are exposed to scientific evidence that goes against what they were taught. and now they are like stuck between two oceans, trying to decide what to do, and the patient are telling them, no, 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 you should go towards what they taught you, and your clinical instructors or your colleagues, usually your colleagues, so will say, no, 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 what are you doing, bro? Like, just do a massage and you are totally fine. Or your boss, usually your boss will say, I don't know, you are going to spend 1 hour doing manual therapy to this patient. I remember some job offers out there when I was looking for a job that were like, uh, I remember especially one that was like, sessions will last 45 minutes and will be a manual therapy lead. Like, that was their way of saying, no, no, you're going to practice the way that I believe you're going to practice. If you don't like it, you are not going to work for me. And the way in which I envision you is you're going to do manual therapy for 45 minutes. Like, forget about exercise. Educate. You can do educational therapy. Education. You can educate the patient during the manual therapy with the limitations that come with that. And if you don't want to, you can leave. And I think that, even if it sounds like bad, we could take the license of many physical therapists, to, let's say, diagnose, prescribe exercise, even use machines like electrotherapy, and they wouldn't care because they would practice the same way some physical therapists are doing, like 1 hour manual therapy sessions, and for the next one,
Yeah.
and that's it. Like, they work as massage therapists. There's nothing wrong with massage therapists, but I think that we as physical therapists, with the education that we have, we should strive for more.
Yeah.
And I think that it's depressing, but again, that's reality, and that's usually, the reason why many patients, or most patients, think that we have physical therapists do manual therapy and forget about everything else.
Yeah, it's a reality, and we can work to make the reality better. This is
Yeah,
the end.
we don't have any other option.
No.
Absolutely.